Okay. A very good morning to all. Respected judges of the panel and all members of OSAPCON, warm greetings to all. I am Dr. Soham Shrikant Ranade, postgraduate of Guntur Medical College. My guide is Dr. G. Varaprasad Sir, Professor and HOD of Department of Orthopaedics, and my OSAPCON paper ID is OSVP 327. The topic I would like to present today is learning to operate with another virus, prospective study of orthopedic cases in a tertiary institution during COVID-19, exactly how COVID affected us. When 2020 came, we all were very excited and eager to welcome it. Little did we know what would unfold before us. On 24th of March, for 3 weeks, Prime Minister Narendra Modi, he imposed national lockdown. Even after that, lockdown extended up to 31st of May. Because of all this, panic started and more speculations and predictions began. All systems became haywire. No one knew what is happening. As an orthopedic resident, we discharged most of the post-op cases and we stopped all the elective admissions. Coming to the facts, India has recorded now 1.1 crore of corona cases. Maharashtra has always topped the list. Maharashtra is always number one corona-philic, but Andhra is not so behind. Andhra is fourth in the list. As for our hospital, we have recorded around 12,000 cases and about 612 deaths. All these numbers just show us the magnitude of cases which we have gone through. Now, how has it affected orthopedics? Traditional electives like arthroscopy are very easy to decide, but are all orthopedic cases, are they all electives or only the ones which are limb or life-saving ones? This question has no definite answer. In our study, we have followed up cases which have presented to us in COVID, in GGH casualty, and we have found some interesting observations. I hope these findings, they share identity with the experiences of orthopedic surgeons of Andhra Pradesh during COVID times. Now, my aim is to know the effect of COVID-19 on orthopedic patient management, also to find out what the problems we faced and also what scenarios we encountered during COVID from an orthopedic surgeon point of view. When I started my residency in May 2019, we calculated the number of operatives which we have done, say 6 months pre-COVID and 6 months during COVID. We found that 843 was the number which we operated for 6 months before COVID came, and the number was reduced to 188 during the COVID onset from April, say, to September 30th. The highest number was seen in September, naturally because of relaxation of lockdown and resumption of non-COVID work. Here we can see a dip which is seen, say, in March 2020, when COVID actually started, and again a rise in operatives in September 2020. Now, just to know some of the facts, initially we would operate most of the cases. We would operate about 281 cases out of 322 of fractures around the hip, and once COVID came, we had to send most of them conservatively. So we operated only 22 out of 98 cases. Similarly, fracture shaft of tibia, we would do closed nailings for 194 out of 269 cases. I mean, that was the number of which we would do closed nailings. But as patient came to us late in COVID times, we had to do open reductions and closed nailings decreased to 15 in 32 cases. So the observations become, number one, cases presented to us late. Because of lack of public transport, no trains, no buses, patient came to us late. Because of all this, we had to do, again, open reductions rather than closed. By open reductions, it meant more blood loss, more hospital stay, and increased risk of COVID transmission. One interesting thing which we found out that because of lockdown, there were less RT cases, but people had more free time. So there were more assault cases, more trivial falls in the elderly, and more fall from trees. So fall from trees and assaults, they increased. Trivial falls were the same, but fall from trees was more in search of alcohol. So people would climb toddy trees. We had more cases of calcaneum and spinal injuries along with ulnar fractures in COVID times. Prolonged workup. During COVID, the mandatory test required before OT was a recent COVID test. Initially, we did not have rapid kits. We had to rely on RT-PCR, and the reports came after 24 hours. So this meant that our decision time had to be increased and workup had to be extended for the result to come. Sometimes we had to repeat the test as the test was considered as null and void due to lack of sample. No stock. The infrastructure was overburdened. We had less PPEs, less N95s, sometimes even shortage of them. Anesthesia people were reluctant to give general anesthesia cases. As we know, intubation increases the risk. Therefore, conservative management was done for most of the pediatric cases. Corrections like CTV, they were postponed. An interesting thing which we found out that the patients which we had sent by conservative management, there was increased COVID incidence amongst them. So the finding led for us to understand that possible reasons being because of old age, there is increased comorbidity in them. Because of this, we are immobilizing the patient. There is increased retention of secretions, which is making them more prone for COVID infections and COVID vectors being COVID patient attenders. So earlier we mobilize them, earlier the better. COVID hospitals. Ours was one of those few hospitals which were doing both COVID and non-COVID work. Also, our staff was divided in both COVID duties and non-COVID duties. We had to face most of the referred cases, and it became difficult for us to manage both of them simultaneously. Every month, phobia of transmission. How is COVID spreading? Some are saying by cautery, some are saying by laminar operating room. So it was very difficult, and this led to a lot of phobia and panic amongst all the orthopedic surgeons. COVID positive compound cases were very difficult to tackle as there was a lot of associated infrastructure which was necessary for dealing with these cases. Separate PPEs, separate N95. Most of the times we did not have adequate supply of these things. We becoming positive, the domino effect. If one patient is positive, it led to transmission of COVID to other patients and other faculty. Teaching hospitals. Ours was a teaching hospital. For about 6 months, there were no cold cases. We felt the lack of case taking and examination. How do I get implants? Implant production was hampered. The supply was reduced. There were no couriers, no trains to transfer. Also, there was no way by which we could avail the implants. There were district boundaries. The vendors had to go to the district boundaries to sign an affidavit and get the implants. Exposure was always first, which meant that patient did not know his COVID status. We did not know. On treating the patient, doing primary care, we came to know his COVID status, thereby in a way affecting us and infecting all the people around us. The conclusion being, the earlier you operate, the better it is. Earlier you mobilize, the better it is. Also, with standard protocol in our setup, it is able to redefine the emergency case definition. It is necessary to take most of the cases as emergencies, to do operative procedures from them and mobilize them as quickly as possible. Now, it has affected all of our lives. COVID-19 is not just based on 2019. We are in 2021 and it is still affecting us. Orthopedic surgeries are no longer conservative surgeries. They have to be operated and managed and mobilized as early as possible. Here in our hospital, what the protocol which we follow is, when a patient comes to casualty, we will do a rapid COVID test along with other tests. If he is rapid positive, we will send him to COVID ward and do conservative management. Ask him to review once he is COVID negative. If he is COVID negative, rapid negative, will admit and then confirm with RT-PCR. A COVID positive patient requiring OT will be sent to a designated OT for COVID positives, only for COVID positives. There will be a separate team, separate N95s, PPEs, and respirators will be given to the surgeons, and the patient would be operated there. What is the take-home message? COVID is here to stay. We have faced it so far, we have tackled it so far, and the cases are now even rising. We can't run anymore. We have to tackle it, and we will do it again. As we can see, Maharashtra is still having more number of cases day by day. With the adequate precautions, it is necessary to mobilize the patients, especially elderly, as soon as possible, and the patients who come with fractures of the lower limb. Orthopedic trauma is no longer elective trauma. We can test the patient, we can operate if negative, delay the recovery if COVID positive. COVID positive compound cases should be treated separately. The designated team should go and operate these cases in COVID positive OT rooms. A rapid COVID screening test is a must in scenarios like casualty, where hospital personnel and other patients are exposed all at once. We should continue the measures which we have been taking so far, like fumigation of hospitals, use of N95 masks, sanitization of hands and social distancing, and promote vaccination as much as possible. That is the way forward. Have you? So with all this, what I mean to say is, like we deal with HIV, HBsAg, and HCV, Corona is one more virus which we have to include. We deal with triple H very well. We have to deal now with triple H and C. Thank you so much.